All right. Good morning, everyone. Good morning. Thank you. One person. I'm Dr. Ilana Yurkiewicz. I'm a Stanford physician, journalist, clinical associate professor, and the co-faculty director of Big Ideas in Medicine with Dr. Brian Lynn. Oh, thank you. And we are truly delighted to welcome you here today to what is our third annual Big Ideas in Medicine conference. Our theme this year, which we spent a lot of time thinking about, is discerning truth and rebuilding trust in medicine, a topic that I don't think could be more timely. I wrote in the welcome letter about a patient of mine I called Mike, a man with metastatic prostate cancer. At our first visit, he said to me, "I need you to tell me if I'm going off the deep end." I quickly understood why. He told me how he was done with traditional cancer therapies that had caused many side effects: chemo, radiation, and hormone blockers. We agreed that more treatment would not help him live longer or better. We disagreed on what came next. I spoke about palliative care and hospice. He spoke of blue scorpion venom and mistletoe. I pointed to prescription medications. He pointed to expensive supplements. I cited PubMed. He cited TikTok. My challenge was to find some middle ground, to tell Mike the truth and find a way to help him, even if he had lost trust in the kind of help I was trained to offer. Mike is not an anomaly. I've been a doctor for 10 years and I've treated thousands of patients. It is a different world in medicine today than 10 years ago, 5 years ago, and even 6 months ago. Trust in the medical profession is declining. Studies show this, and I know it from what my patients ask me every day. I can tell you exactly the latest trends without clicking on any link. Most of the time, my patients bring them up shyly with a hint of embarrassment. "I read this online. What do you think?" And when I say there's no evidence, they let it go and we move on. Then there are a growing number of people like Mike. Shortly before him, I cared for one woman in her mid-40s who declined surgery and chemotherapy for colon cancer in favor of a naturalistic approach. The difference between her and Mike? Her cancer was curable. After a very long conversation, I told her that without treatment, the cancer would take her life. I also told her the good news, that we had the treatment to save her. She made her choice to go elsewhere, and I never saw her again. How did we get here? I believe the reasons for this nadir in trust come from both directions. It's push and pull. The push, a negative experience with healthcare. The pull, the glamorous alternatives. The push, in one word, is access. Let's do an experiment, and I promise I won't call on anyone and put anyone on the spot. We have many doctors in this room, but raise your hand if you have a doctor who you like and trust. Almost the whole room. Raise your hand if you find it easy to get in touch with that doctor when you need to. About a third of the room. Now raise your hand if when you can't access your doctor, you've done the next best thing and looked for medical information somewhere else. Pretty much everybody. The average wait to see a new doctor in the United States today is 38 days, up from 26 days just 3 years ago. This is going in the wrong direction, and it's in every part of the country, in every medical specialty. I try to refer to my patients to a local neurologist. They're booking into 2026. Psychiatry, try a year. Access to medical professionals is at an all-time low. I couldn't even get an appointment with myself. Why is this happening? Are patients that much sicker? Is the doctor shortage that severe? Neither explanation is quite right. It doesn't explain why specialties that are growing in physician numbers are booking so far out. And it doesn't capture why cities with the most favorable doctor-to-patient ratios top the list in difficulty getting appointments. It's something else, both more mundane and more bureaucratically nightmarish to fix, because it can't be solved with training and hiring more bodies. It's a radical labor mismatch. We've built a system where doctors' expertise and patients' needs are misaligned. What do I mean by this? In an increasingly complex healthcare system with many players, including electronic charts, payers, specialists, the work to move medical care forward goes far beyond the face-to-face. Here are the stats. Every 8-hour day treating people generates over 5 hours of administrative tasks. Meanwhile, the system hasn't caught up in any meaningful way. Payment models still reward appointments, not modern communication channels like emails or calls as the sole currency of care. Outside of emergency rooms, scheduling still favors first come, first served over medical need. The result is a cascading failure. Primary care practices like mine balloon to thousands of patients, each requiring more work, vying for a flat number of appointments. Precious slots fill with issues that could otherwise be managed with a quick back and forth or a chat with a nurse. Specialist schedules then clog with cases any solid general practitioner could resolve if only they had the time. So everyone waits. When access to medical professionals is weak, others will step in and fill that void. I believe there are 3 disruptors: influencers, AI chatbots, and catchy political movements. First, influencers. A 2024 survey showed that over half of Americans turn to social media for health information. Less than half of that information is accurate. One University of Chicago study looked at the most popular TikTok videos on sinusitis. 47% were right. And no offense to anyone suffering from sinusitis, but there are parts of medicine where the stakes are even higher. Unlike medicine, where we have years of training, board exams, and certifications, social media requires no standards to impart medical information. All you have to do is set up an account. Success is not based on skill or substance, but rather a good old-fashioned popularity contest. There are good sources out there. Our keynote today, Dr. Will Flannery, is one of them. But as a patient, how can you tell the difference? The ones who impart untruths sound like your friend. They're personal, they're comforting, they're reassuring. There are more ways than ever to monetize being a wellness influencer as a career. And so they're everywhere. Next to fill the void, AI chatbots. At least once a week now, a patient says to me, "I couldn't get in with you, so I asked ChatGPT." The good news is that chatbots are much more accurate than influencers. A much-cited headline by the New York Times showed that AI defeated doctors in diagnosing illness with a 90% success rate compared to 74%. Another study showed they passed medical licensing exams. Already, these beliefs of superiority are permeating the thinking of the medical community, subtly eroding trust in colleagues and even in doctors' own minds. Especially for young doctors still in training, the danger is seeing AI not as a tool or an assistant, which I believe it certainly can be, but as the answer book. This is despite the disclaimer on every chat: AI can make mistakes, check important info. When uncertainty is high, which is medicine's constant state, AI answers with welcomed clarity, whether it's truth or hallucination. Doctors should be fact-checking AI, not the other way around. And for patients, the danger lies in how AI is trained to have a validating, encouraging, what some have called a sycophantic tone. There's a lot to learn about the best ways to incorporate AI into modern medicine. As we do, there have already been real and tragic cases of chatbots propelling mental illness and even suicide. And finally, catchy political movements. The premise of the latest sounds good on paper. Chronic disease is rising, and we need to look into root causes. I don't disagree. We should focus on nutrition. I don't disagree with that either. But when led not by medical professionals, but by litigators, litigating and relitigating problems that have already been solved, these efforts are at best a distraction from the most pressing issues in medicine, and at worst, unravel evidence-based practices that work. Here are some examples. Vaccines in children. Antidepressants in pregnant women. A hyper-focus on issues on the margins, like food dyes, rather than the food itself. The defense is always the same. It's not been studied. We need more research. Well, we could also do a study on whether the change in tides causes autism. We wouldn't because it doesn't make sense to invest limited policy dollars and research efforts into something that is not biologically plausible. Of course, some skepticism has advanced medicine. The other obvious truth is that not everything needs more research. We have real problems that deserve our attention. Flattening everything into equal importance allows the movement to wear a veneer of unique scientific inquiry, when in reality, deep dives are what doctors and the medical research community does every day. What do these disrupting forces have in common? They're confident, they're charismatic, they lack medical degrees. They use new media and direct-to-consumer tactics. They've hijacked nice-sounding words like holistic and natural. They wear a cloak of contrarianism and call it courage. But they're available. Not only available, they're in your face. They're on your phones, in your pockets, in your ads. And they're targeting people in their most vulnerable state, when they're sick and desperate for help. This is the perfect storm. This is what we are up against. At the same time, when doctors are least available, bad information is most available. Not all hope is lost. When my patient Mike sadly passed away, it was not a surprise. But my conversation with his brother the next day was. He told me that Mike didn't suffer and that he died at home. And then he said, and those medicines really helped. Medicines? I repeated. Over the phone, I could hear him rummaging through pill bottles, and he started sounding out names I instantly recognized. After all of our back and forth, to my great surprise, he said, if it had your name on it, Mike took it. No questions asked. We must think of creative ways to tackle the access problem as the crisis it is. And we must regulate the spread of bad information without infringing on speech. But there is something else we can all do now. Mike taught me that in this new world, the honest, measured conversation is our sharpest scalpel. We can admit uncertainty. We can be transparent about what medicine does and doesn't know. We can validate bad experiences without validating bad information. We can avoid the dual traps of groupthink and skepticism for the sake of it. I'll be first to admit it doesn't always work. Some people are fully submerged in the deep end, but others have dipped a toe. And on the whole, it's mutually reinforcing. Telling the truth restores trust, and earning the public's trust lets us amplify more truth. That is why we are here. This is the setting. I thank the speakers and the organizing committee and the sponsors who have made this event possible. I hope the next 2 days are enjoyable and thought-provoking. But more than that, these conversations are our greatest hope. They are the path forward to discern truth and rebuild trust in medicine. Welcome to Big Ideas.